Hello, John. Can you hear me?
Yeah, hi.
Hi, how are you?
Welcome.
Good morning. Thank you so much. If you want, we can do a very fast technical check if you are ready.
Yeah, go
What do
ahead.
you think about?
Yeah, go ahead.
Okay. I share my screen.
All right.
Just let me know if everything is okay.
Yeah.
Can you see? Can
Yeah,
you see my slide?
yeah, perfect.
Can you see my slide, the other one?
Yeah, beautiful.
Okay. Nice.
Bella.
Okay. That's okay. I stop to share the screen.
Yeah, you were in Boston too, right? We televised you in Boston, right? From Brigham. Did you?
I was in Boston as a fellow.
Yeah, we televised that.
Sorry, my connection. Yeah, can you hear me now? Because my connection is not so good. I'm scared just about the connection. Can you hear me now, yeah?
Yes.
Okay. I hope to don't have problem with connection because connection today is unstable. I don't know why, but anyway.
Oh, where are you now?
Now I'm in Italy. I
Oh,
came back from, yeah, I spent 6 months in Boston for my fellowship and then. Hello, guys. Thank you.
Hello, Sabina. Hello, John. Beth.
Oh, how are you?
Hello, everyone.
welcome.
Professor Satova, thank you so much once again for this kind invitation.
Thank you so much for accepting. Thank you, everyone.
Thank you. How
Yeah.
are you?
Do you hear me? Yeah, really?
We can hear you. You are audible and visible, so everything
Okay,
is nice.
thank you.
Yeah. We did our technical check and everything is okay. I'm just scared about my connection that today is not so good. I don't know why, but anyway, just in case, please take your words and go. Be ready for this. Argiza, okay? No,
Okay.
I'm joking. No,
Yeah.
I'm joking. I'm joking.
Yusenko, do you want to go over your presentation? You've done this before, right? Dr. Senko,
Yeah. Mm.
do you want to test something
Okay. Can,
if you want?
now I'm sharing my screen.
Yes, yes,
You,
please.
you can see? You can
Not
see?
yet. Not yet.
Not yet. Where's the sharing?
Share screen. Третья иконка снизу.
Share screen, I know. Mhm. Okay. Now?
Now we can see your screen.
You want it on presentation mode at the bottom, one of those icons.
Okay. You can see our presentation?
Yeah,
Yes.
sure. Launch your presentation in viewer mode as full, just to check.
Okay.
At the very bottom, there's an icon. Click on that. There you go, down at the bottom, yeah. Oh, at the bottom right.
Так, справа снизу должно быть.
In the bottom
Wait,
right.
Did you find?
Yeah, very close to the zoom button in the presentation, in the bottom of the screen. Where you see 95%, just on the left. You see zoom, and just on the left, the other button.
At the bottom.
In the bottom, right bottom. You should be also launched with F5 button, to the best of I remember.
Nargiza, are you there?
Yes, yes, I'm here.
Could you
Илья
explain-
Владимирович, вот
could
Yeah,
где...
yeah.
Да-да, нашли?
Nargiza, could you
Yeah,
explain?
that button.
screen
Okay.
share, please?
Yes. Slideshow.
Wait.
Now we are
And
not
we-
able to see. Ага. То есть на slideshow it is not working, right, or what? Если нажимать на slideshow, мы не видим ваши слайды.
Now?
Now, no, you are not on slideshow mode.
What?
Okay, you need to go to the bottom of the screen, the bottom.
Yeah, I know.
Yeah, and there's four
Yeah,
icons.
that,
There's four icons. You click on one of those icons. There, perfect.
Yeah,
There you
perfect.
go.
Yeah.
Yes, you got it. You got it.
John, I'm so sorry. Some people are telling that one of the link is some African link. Can you just send me the proper link one more time on WhatsApp? So I will forward it to everyone.
Okay.
John, could you send me please the link?
Yeah, you know where it is.
Yes, but I also Neurosurgical
You don't
Sunday.
have to get it from me.
I can start?
Так, 1 second. Мы ждем Илью Григорьева. We are waiting for Dr. Ilya. 1 second.
Okay.
Okay, there's a direct link, Nargiza.
Yes. I see. Thank you. Just a second. How many? Like we have 7 participants for now. Вот, Ilya Grigoriev. Can you make Ilya Grigoriev as a panelist, please? Okay, now. Great. Все, Илья Григорьев подключился.
Yeah.
Okay,
Отлично.
your co-host, Nargiza, you can also admit people too.
Yes, thank you.
Hi.
So, good morning, Dr. Ilya. Good morning.
Morning.
good morning.
Good morning.
Good morning, everyone.
Hello, everyone. Are you already online, John? Yeah.
Yes.
Yeah.
We got about
Who is
5
the
minutes.
first of us? Professor Grigoriev is the first in the timetable?
The first one is Dr. Ilya Sinko.
Okay.
The second one is Dr. Sabino Luzi. And
Okay.
the third one is Dr. Ilya Grigoriev. So we can start.
Okay. Granted, dear colleagues.
Nargiza, I'm
One
the
second.
boss.
I'm
I'm
going
the
to
boss,
introduce. Good morning, everyone.
No, hold on, Nargiza. Hold on, Nargiza.
Yes. We have to start recording. Then we will go for introduction, and then I will give a word to Dr. Ilya.
Yeah, I'll let you know when we start, okay?
Yes, okay.
Yeah. We got about 3 minutes.
After 3 minutes, we are starting.
Exact, but
Yeah, I'm waiting.
And then we are going to televise it in YouTube.
Okay.
Так.
is it snowing in Moscow?
No,
No, you're not in Moscow.
Dr. Ilya, is it snowing in Moscow?
Moscow now.
Yes,
Yeah, it's snowing. Yeah, we have.
little bit.
Snowing now already.
Beautiful,
Wow.
Dr. Ilya recently came back from Germany, by the way. He was there.
Yeah, it was a nice night. From Freiburg.
Yes. So your mentor is also skull-based and vascular neurosurgeon in German?
Both.
Both, okay.
Yeah, Dr. Senko, I'm going to take you off the screen until so I can introduce the channel, okay?
Mhm.
Introduce the show, actually.
Okay.
Okay, we'll start in 2
I
minutes.
see. I see.
Yeah, that way we can, when we introduce you, we can see you. Well, that's what we like to do it anyways, if we can do it. It's sunny in Miami, but not now. It's the morning time. It's 5 o'clock in the morning.
5 o'clock in the morning. Oh,
Yeah.
wow.
I'm
You
trying
will
to
take advantage to see the sunrise, right?
Yeah, well, I want to be like a neurosurgeon, so I keep neurosurgeon hours.
Yeah, sure. You're working so hard.
Well, you know, 5 o'clock is not early for a neurosurgeon. You know, that's just part of the game.
Congratulations for your beautiful effort. You do lots of things for neurosurgery, and because of you, neurosurgery all over the world is advancing now.
Well,
Thank you.
well, you know, it's a really, you know how you enjoy operating. I'm the
Yeah.
same way with televising. I'm the same way. It's not a question
Sure.
of hours.
Sure.
You just enjoy
Yeah,
yourself and
but-
you forget the time.
Sure. But our friendship and our relationship all over the world is very productive for all of us and for you also, because
Yeah, I hope so. I hope so.
we spread neurosurgery through you.
Yeah.
Well, we like to. I'm surprised. Russia, we're getting very good response.
Yeah.
Thank you.
We just started doing more of these webcasts, and
Thank you, John.
thanks to Nargiza
Thank
and
you.
being able to put everything together, which I wouldn't normally have time to do, and I don't have the connections that someone like Nargiza would have. So that helps. The more connected we get, the better.
Nargisa is international.
Yeah. Yes.
Nargisa should be the next president. She will candidate.
Okay. Well, this is where the convention is going to be. We're just going to have the speakers come to the convention, not people watching, just the speakers. Anyway, we're ready to start. 10, 9, 8, 7, 6, 5, 4, 3. Good morning. This is Dr. John Bennett broadcasting from sunny Miami, the home of neurosurgical TV. We have another Russian neurosurgery grand rounds arranged by Nargiza, who you'll meet, and she is basically running the show. Welcome, Nargiza.
Good morning, everyone. Nice to meet all of you. Today is our fourth webinar, Russian Neurosurgery Grand Rounds. And today we will be talking about approaches and vascular disorders. So let me introduce our first speaker, Dr. Ilya Sinko, MD, neurosurgeon, head of the Department of Federal Center of Brain Research in Moscow. Graduated from military academy named after Kirov. He is a member of a lot of societies. One of them is AANS. Several years he has been working in emergency hospital named after Sklifosovsky. And today he will be talking about surgical treatment of distal cerebral aneurysms. Dr. Ilya, please.
Okay. Great and dear colleagues, thank you Nargiza and John Bennett for your invitation and the opportunity to share our experience in a very special topic. We want to share our results of 20 years of our teamwork and try answer the main question, how to treat distal cerebral aneurysm. So when we talk about this relatively small group separately of all other types of aneurysm, firstly because distal aneurysm has its own unique features. They present challenges for surgeons, not only because their presentation is relatively low and anatomy is not usually as straightforward as the typical anatomy in more classical proximal aneurysm. And now absent of strict treatment strategies. About distal aneurysm, we have 2 patients with 18th aneurysm and 11 and 8. It depends how we should treat. Wait and
Dr. Ilya, Dr.
Yeah.
Ilya, I'm so sorry. Could you share your screen, please? We are not able to see.
Yeah.
Yes, you are not able.
Sorry.
Okay, we are waiting.
Yeah, just like you did before.
Before, yes. Yes.
Yes. Now full screen and presentation.
Side.
You can.
Perfect.
Now we can see. Yes.
Perfect.
Yeah. What we talk about distal aneurysm, I spoke earlier. But we have, for example, distal aneurysm to patient with 18th aneurysm. Left cases is 11 aneurysm and 7 aneurysm. And we should treat each patient. It depends on situation. Nowadays, there are a few different definitions of distal aneurysm, especially among the endovascular or microsurgery surgeons. We think that Micro-Lawton definition of what to call distal aneurysm is bestly described this subgroup of aneurysm. And so distal aneurysm are those aneurysms that A2, A5 segment ACA, M2, M4 segment MCA, P2, P4 segment PCA, all segments of cerebral arteries distal to the vertebral artery and basilar artery as a rare location. Reason of formation of distal aneurysm differs of those that lead to formation of proximal aneurysm. Among those we need to mention the hemodynamical and mechanical factors, especially the bacterial etiology and more during infective endocarditis and oncological distal aneurysm, more often during myxoma. All patients in our group were operated in modern microsurgical era. Patients that were operated and endovascular surgeon were operated since 2014 year. We have 198 patients with 3 distal aneurysm. In open group was 153 and endovascular group was 45 patients. About term distalization, among all treat aneurysm, 40.5% was distal. Among all aneurysm, the cerebral aneurysm treated by our team in past 20 years. Posterior circulation was more prone to so-called distalization. More than 25% of aneurysms in that location with distal in nature. About clinical presentation, majority of aneurysm in our group initially presented with rupture and intracranial hemorrhage. Less than 10% of patients experience different symptoms without the signs of rupture, and least of all were incident. Localization distal aneurysm. More often we saw distal aneurysm in ACA and MCA territory. Most of them on A3, M2, and P2 segment arteries. Distal aneurysm, in contrast with proximal aneurysm, were more often fusiform in nature, especially in posterior circulation. Nearly 15% we can see and fusiform type. About size of distal aneurysm, majority of distal aneurysm were small size. Because of these factors, we consider that calculators that based on the result of ICU-IA study couldn't use in patient with distal aneurysm to predict risk of rupture and further choose of surgical strategy. Wide neck wide neck in distal aneurysm was in 32% cases. About open surgery, our treatment strategy were based on different international guidelines. Clipping of aneurysm with preservation of parental artery was our main surgical aim. We use clipping, trapping or excision, and wrapping. Majority of distal aneurysm in our series was treated with primary reconstruction clipping. This option was in 75% of treatment patients with distal aneurysm, compared with 95% of primary clipped aneurysm in proximal aneurysm cohort. Trapping more often was performed in PCA territory. Clipping was more often in ACA aneurysm. Neuronavigation is the mainstay in additional to the microsurgical treatment of distal aneurysm. Especially, we found it more conventional surgery of ACA, MCA, P3, P4, PCA. We don't use navigation in patients with distal aneurysm of cerebral artery because we have large number of anatomical landmarks. About near navigation for patient with pericallosal aneurysm, why we use navigation? First of all, avoid entering the frontal sinus. Second, choose optimal and shortest trajectory to aneurysm. Third, save the big bridging vein. For MCA aneurysm, navigation can help us to do minimal Sylvian fissure dissection and reduced brain injury. Second, orientation in Sylvian fissure with subarachnoid hemorrhage and preoperative planning of cerebral revascularization. We use three types of bypass for during distal aneurysm surgery. First of all, extra intracranial bypass, reanastomose, and reimplantation. As we use the revascularization as a adjunct to conventional microsurgery, we need to consider some problems. First, how to check its patency. We use four methods: Ackland test, biforceps, flowmetry, microdoppler, and ICG. In our opinion, best strategy of patency assessment is ICG, video angiography. We made this consider based on need of small arteries visualization, lack of injury of vessel, and repetition possibility. Ackland test could be used alternatively, but it has some limitation. After clipping vessel obstruction, we can catch nearly 18%. After it, reclipping was made in 10%, bypass was in 3%, and trapping was nearly 5%. Since 27th, we performed 8 bypasses for patients with distal aneurysm. Of all them were in ACA and MCA territory. Need of the technique in no more than conventional aneurysm group, they made it in 5% of all. ACA, MCA, distal aneurysm are more prone to revascularization due to its anatomical factors. More suitable for ACA to use intracranial bypass by reanastomosis or reimplantation. For MCA, more suitable to use extra intracranial bypass because we have good artery for bypass a superficial temporal artery. For example, revascularization MCA aneurysm left cases with big distal aneurysm M2 segment MCA aneurysm was prepping, and after we made extra intracranial bypass with using STA. After control aneurysm you can see, and right cases for patient with M2 also aneurysm, we used made and intracranial bypasses after excision aneurysms. Revascularization ACA patient with ACA aneurysm. Left case extra intracranial bypass with using radial artery graft between common trunk STA and A3 ACA segments. Postoperative control, you can see patency bypass. More comfortable and more suitable for distal aneurysm ACA, you can use intracranial bypass. For example, reimplantation callosal marginal artery after excision aneurysm, reimplantation callosal marginal artery to pericallosal artery. About results our surgery. To assess this treatment result, we divided all patients with distal aneurysm into subgroups, ruptured or unruptured aneurysm. Outcome was assessed by Glasgow outcome scale. Relatively high mortality was registered in patients with intracerebral hemorrhage that lead to brain herniation and vasospasm, especially in patients with pericallosal artery aneurysm. You can see our result about ruptured cerebral aneurysm. As you can see, worst results were in subgroups and ACA and PCA aneurysms. Initial condition, aneurysm location, and severe preoperative vasospasm were the mainstay of poor outcome. For unruptured aneurysm, of course, treatment result of patient with unruptured aneurysm were better. Only one patient with pericallosal aneurysm died because of pulmonary artery embolism. Among patients with unruptured distal aneurysm, worst outcome were seen in PCA group. The main factors of poor outcome were aneurysm size and location, especially PCA artery. Some words about bacterial cerebral aneurysm. It's a very special patient about pathogenesis of formed aneurysm rupture. Bacteria come inside vascular wall, and after became pathological vascular remodeling, and after it two-way. More often we can see vascular occlusion and ischemia, and more seldom we have aneurysm and with rupture. The optimal diagnostic method is a digital subtraction angiography. According to various authors, up to 25% of small bacterial aneurysm are not diagnosed by CT or MR angiography. The optimal the optimal treatment method is an endovascular occlusion of the aneurysm or artery. Bacterial aneurysm have the following features: small size, 5 millimeters, anterior circulation, distally location, and high rate rupture. For example, a patient with bacterial aneurysm. Bacterial aneurysm, most common patient in infective endocarditis. About 5% of patients with infective endocarditis exhibit them. The clinical example of patient operated in the cardiac surgery center for infective endocarditis on the head valves. On the 5 days after surgery, clinical picture of intracranial hemorrhage was detected, and CT angiography revealed distal NCA aneurysm. We made decompressive craniotomy, removal of hematome, and excision of distal cerebral aneurysm were performed. About some words of traumatic cerebral aneurysm or injury artery. Histologically, traumatic aneurysm can be categorized as true, false, or mixed. True aneurysm involved disrupt of intimal and variable involved of the internal elastic layer and media, which leads to localized weakening of the vessel wall and aneurysm formation with adventitia of the native vessel intact. This phenomenon is presumably secondary to flow dynamics against the weakened vessel wall. False aneurysm are considered to be the most common histological type. This lesion results from disruption of all 3 layers of vessel wall with formation of the contained hematoma outside of vessel. False lumens developed creating and aneurysm dilatation. These are presumably the histology type associated with penetration injury. Traumatic aneurysm, less 1% among all of aneurysm. More often, we can see this aneurysm during skull base and bone fracture from faults and tentorium. Blunt trauma, penetration trauma, iatrogenic injuries. You can follow to the formate traumatic cerebral aneurysm. More often, we can see this aneurysm in anterior circulation, more often ICA, more seldom the posterior circulation. We have classification of traumatic intracranial aneurysm. About treatment, we can use open surgery, we can use endovascular treatment. For open surgery, the same methods: clipping plus bypass, or only excision and delete intracerebral hematoma. For endovascular treatment, we can use 3 methods. It's a direct artery embolization, parent artery occlusion, and new technology. It's a parent artery reconstruction by flow diversion stent. For example, the patient suffered a severe traumatic injury in 28th year, for which she underwent surgery. In 2022 years, due to headache, and she performed MRI of the brain, which revealed distal cerebral partly thrombosed MCA aneurysm. The aneurysm was located in the area of the previous operation. The patient underwent excision of the aneurysm and cranioplasty with titanium plate. Also, we have a distal aneurysm in patient with moyamoya diseases, for example, clinical example of patient with rupture aneurysm of the lenticular straight artery with moyamoya angiopathy. And first stage was embolization of the aneurysm, and through the 6 months, we made STA extra-intracranial bypasses. Some words about endovascular surgery for distal aneurysm. More often, ACA aneurysm treated with endovascular technique. Majority of them operation is patient with unruptured aneurysm or in delaying fashion. Only 18% of endovascular treatment was made in patient in acute period of hemorrhage. Stent assist, we use all devices, and stent assistant coiling was primary treatment method in our group. Main limited factors for endovascular treatment was small size and anatomical anomalies of parental arteries. Distal aneurysm of MCA and cerebral artery was more prone to unplanned occlusion of primary artery. You can see example use endovascular treatment distal aneurysm. ACA aneurysm, classical A3 segment ACA. We use coil with stent assistant with good occlusion. Flow diverters was used in 30%, especially for distal aneurysm in PCA. Apparent artery occlusion we used more often for patients with distal cerebral aneurysms. Result of endovascular treatment treated group was similar to the microsurgery group or for unruptured distal aneurysm. In this group, we experienced only one mortality case in patients with intraoperative rupture PCA aneurysm. About evolution, in our viewpoint on the distal aneurysm, treatment could be seen in this scheme. Open surgery, first of all, visualization, small aneurysm. Second, vessel control during surgery, near navigation and small approach, bypass surgery, and multidisciplinary approach for occlusion and patient-oriented approach. For endovascular surgery, it's a coil. Change parent artery occlusion to selective aneurysm embolization. Coil-assisted method in small distal vessels. Pharmacy supporting endovascular devices. Small flow diverters and endovascular opportunity in acute stage subarachnoid hemorrhage. About our strategy for ruptured distal aneurysm. In choosing the right treatment option for ruptured distal aneurysm, we could divide three mainstays. Presence of space occupying intracerebral hemorrhage, initial condition, and aneurysm location. If we have life-threatening dislocation, we must use open surgery with reconstructive or deconstructive clipping. If we haven't dislocation, it depends of initial condition patient. If patient has within AS1 or 3, we use open surgery, especially for patient with ACA, MCA, and pica aneurysm. If you have patient with posterior circulation, posterior cerebral artery, we use endovascular embolization. Also, for all patients with poor grade condition, we use endovascular embolization. About strategy for unruptured cerebral distal aneurysm, main factors that influenced our decision were location and shape and present of mass effect. If we have mass effect, we use in any case open surgery with both methods. And we haven't mass effect. It depends aneurysm localization. For aneurysm ACA, MCA, PICA, we made a reconstructive clipping. For PCA aneurysm, more suitable endovascular embolization if only aneurysm and parent artery occlusion. In conclusion, my presentation, distal aneurysm was, it's very rarely, only 5% between among all aneurysm with small size, wide neck, and fusiform type. Clipping performed only in 75% of distal aneurysm cases, and trapping was in 25%. Parent artery occlusion after clipping was in 18%. Bypass were done in 5% of patients with distal aneurysm. Worst outcome in PCA and pericallosal artery aneurysm. Best outcome was in MCA and PICA aneurysm. Endovascular treatment of the distal aneurysm equals microsurgery in treatment outcome in patients with unruptured aneurysm. And patient in poor clinical condition or PCA aneurysm better treated with endovascular surgery. Thank you for your invitation.
Thank you so much, Dr. Elia, for your nice and good presentation. Do we have any question from audience or from panelists? Anybody?
Just a comment.
Any comments?
And exhaustive presentation of Dr. Senko about very, very complex topic of distal aneurysm. That I want just make a comment, and I want to stress the fact that we have to defend this type of aneurysm because you know, the overall results of endovascular therapy of distal aneurysm are not so good like our. So especially for the ACA, so the anterior callosal artery aneurysm, and also for distal pica aneurysm, we have more option than them today. So we have to defend this kind of surgery, special distal aneurysm are microsurgical today in most of the cases. This is my personal and humble point of view, especially on pica. If they close pica, sometimes I saw many cases where there are some places where they decide to undergo endovascular therapy also for distal pica aneurysm, and sometimes I saw some disaster because you know, the ischemic complication rate is very high for endovascular therapy for distal pica aneurysm or caudal loop, cranial loop, and so on. So I do believe that this subgroup of aneurysm are still 100% or almost 100% microsurgical. It's just my comment.
Yeah, I agree with you. First of all, this presentation showed to you and for PCA aneurysm more suitable for endovascular treatment because this aneurysm located very deeply, and sometimes we need retraction, temporal or lobe brain. And about second group for endoscopal treatment, ACA aneurysm. Sometimes if a patient has unwrapped clinical fetus, we can use flow diverters. Flow diverters is now it's against from open surgery, but I'm only open surgery. But our endoscopal team spoke me about we can really.
But you also show some beautiful cases of a revascularization option between MCA and the A3 with radial artery graft, and there are some beautiful options that we can implement in some complex aneurysms. So I believe that this is an option more for us. And for distal aneurysm, you know, flow diversion, it's not so good. So that's the reason why this is my idea. So anyway, thank you once again, and congratulations for your beautiful presentation. You showed us really astonishing presentation and data and overall outcome. Congratulations.
Thank you so much.
Thank you so much. Let us go to our second speaker, famous neurosurgeon, my very good friend, Dr. Sabine Lusi. He is an associate professor of neurosurgery at the University of Pavia, Italy, visiting professor at the University of L'Aquila in Italy, consultant neurosurgeon at IRCCS Policlinico San Matteo in Pavia, Italy, and GMC certified neurosurgeon in UK. Dr. Sabine Lusi is a professor who is a well-known educator, and he is a member of a lot of societies, neurosurgical societies. So he has numerous amount of articles, and today Dr. Sabine will be talking about skull-based approaches for intracranial aneurysms. Dr. Sabine.
Thank you very much once again to my very good friend, Professor Satova, for her kind words. And it's my best pleasure to be here once again with John and with Neurosurgical TV. I believe that this is beautiful family, and I already tell thank you to John, because he's spreading the microneurosurgery all over the world and neurosurgery all over the world. So thank you once again for his beautiful work, and congratulations to all of you. Can you hear me, and can you see my screen? I've just shared my presentation.
Yes, we can see, and you are audible.
Okay, thank you very much. I just want to, the topic of my presentation today is to share some basic principles, especially for young neurosurgery, but also for, it's a refresh for, you know, very skilled neurosurgery, but skull-based approaches for intracranial aneurysm. Skull-based approaches for intracranial aneurysm are the same, or share the same concept of skull-based surgery as one of my best mentors, Professor Al-Mefti, said always, please remove the bone and leave the brain alone. So it means that the basic principle of skull-based surgery is to remove the bone, to drill the bone, to avoid the cerebral retraction, the brain retraction, because never forget that's the best retraction in neurosurgery is no retraction. So we have to gain space through the bone to go to our cisternal target. But when we think about the intracranial aneurysm, we have to tell why skull-based approaches for intracranial aneurysm. Why? The first reason is because we need an early proximal and distal vascular control to this kind of lesion. The second one is the fact that the skull-based approaches for intracranial aneurysm make the corridor shorter and widen, and so the angular exposure of our target is better with skull-based approaches than with conventional approaches. And we also need to increase our surgical freedom to the target, and especially we need skull-based approaches to avoid brain retraction. Lots of people today talk about skull-based approaches, and even yesterday, 2 days ago, I went in a congress, And one guy told me, I was talking about COZ approach, and one guy about some complex anterior communicating artery aneurysm. And this guy told me, but why we need today skull-based approaches? It's excessive for me, because today we perform everything from subfrontal approach or highlight approach, or it's okay. It's okay, but it's okay for some small aneurysms. It's okay for some unruptured aneurysms, but not for complex, giant thrombosed calcified aneurysms. In that kind of aneurysm, we still need skull-based approaches to get our early proximal control, and especially to avoid plate retraction and to avoid the catastrophic complication. The main principle of skull-based surgery is, or not skull-based surgery, but vascular surgery, is to go transcisternal. This is a cisternal, total extracerebral surgery, and we need more corridor, interhemispheric, subfrontal, pretemporal, sometimes subtemporal, and obviously the golden corridor, the Transsylvian approach, and so on, because we want to reach our target that are in different aspect of anterior and posterior cycle. So the main principle of skull-based approach and the main principle for intracranial aneurysm is to get the space and to expose our external target. And now in doing this, you have to be a Spider-Man. You have to be a Spider-Man because you have to navigate the system, okay? And another important aspect in the approach selection for skull-based approaches in intracranial aneurysm, this is my personal and humble point of view. We have three different main factors that affect the approach selection. The first is the need for exposure to the aneurysm, especially if you deal with complex, large, giant aneurysm, you need to expose the aneurysm. Some very, very small and limited keyhole approaches or supraorbital approaches are not enough for the exposure of the aneurysm. The second aspect is the proximal control, what Professor Lawton already stressed about the so-called contingency plan. In dealing with some complex aneurysm, the proximal control is very, very, very important, because you always have to take into account the opportunity and the possibility that the aneurysm, even if it is unruptured, will rupture, okay? And you have to get the proximal control to the aneurysm. And the third one is the strategy. Obviously, it's totally different if you want to clip and deconstruct the reconstructed aneurysm, and if you want to revascularize the aneurysm, and so on. About skull-based approaches, the first type of aneurysm where we use the skull-based approaches are paraclinoid aneurysm. Paraclinoid aneurysm, when we deal and where we talk about paraclinoid aneurysm, we refer to C5 and C6 segment of the paraclinoid ICA in the Boutillier classification. So it is those segment of the clinoid artery, or the anterior carotid artery, that is very, very close to the anterior clinoid process. And we know that sometimes sometimes we can have a takeoff of the ophthalmic artery coming from C5 rather than C6, and it affects the approach selection. It affects my strategy in doing the, anterior clinoidectomy and so on. And this is our classification that I love, that is Professor Krish classification about the paraclinoid aneurysm, where we simply can divide this aneurysm superior, lateral, medial, and inferior. And when we deal with superior projecting aneurysm, I want to stress very well that we have two kinds of aneurysm. The first one of aneurysm, this is because we afforded this, we wrote a nice article that I will show you about the opportunity for proximal control for this aneurysm. About the superior projecting aneurysm, we have two types of aneurysm. The first one are the ophthalmic, where the aneurysm have a very close relationship with the takeoff of the ophthalmic artery. The second one are the so-called dorsal ICA aneurysm, where the takeoff of the aneurysm, the origin of the aneurysm, is not very close to the ophthalmic artery, and the origin of the artery is distal to the origin of the ophthalmic artery. So it is, practically speaking, a sidewall aneurysm. And here, the need for proximal control is totally different in the true ophthalmic aneurysm and the dorsal ICA aneurysm. Let me take a look here. If we deal with these aneurysms, for sure we can use the pterional approach, that is the workhorse approach of scalp-based surgery, but pterional approach just after two different perspectives. The first one is the transsylvian perspective, and the second one is the subfrontal perspective. One of the main principles for young guy in pterional approach is to remove the bone, drill the lateral part of the sphenoid wing to totally expose the system, the ICA system, the MCA system, and so on. And these are the main steps of the approach, but I don't want to lose too much time here to discuss about these approaches. But you have to go as basal as possible when you perform a pterional approach for aneurysm. Why? Because you have to drill adequately the lateral wing of the sphenoid. Because drilling the sphenoid is your space, is your working room to clip aneurysm. So please don't be shy to drill the sphenoid wing. And if you perform this approach in the right way, in the compulsive superiosteal way, you can reconstruct this approach without leaving a cuff, without leaving anything, just to respect the vascularization, the vascular supply of the temporalis muscle. And this is the best way to avoid the temporal hollowing, postoperative temporal hollowing, and the atrophy of the temporalis muscle. And just to show to young people the difference between before and after drilling of the sphenoid wing. You can see here clearly how the system is already open, okay? And this is the door to the anterior sulcus, and this is the opening the door to the anterior sulcus and the parts of the posterior sulcus, and also at the level of the posterior fossa, especially at the level of the interpeduncular system. If you drill adequately the lateral part of the sphenoid wing, you can go almost everywhere in the anterior and the posterior sulcus. Another important concept, when we deal with pterional approach for paraclinoid aneurysm, we have a special concept about the head positioning. The first aspect is the rotation. How many grades I have to rotate the head? I have to make the tip of the anterior clinoid process parallel to the floor. And if you take a look to the orientation, we have 45 degrees of orientation of the long axis of the anterior clinoid process with the midline. So it means that I have to make parallel to the floor the tip of the clinoid. Another important aspect is the deflection of the head. If I want to perform the anterior clinoidectomy, that is the key to treat and to adequately treat the paraclinoid aneurysm, I have to avoid hyperdeflection of the head. Why? Because I need this perpendicular view to drill my clinoid. But if I hyperdeflect the head, I will make the clinoid slip, and I make my anterior clinoidectomy more difficult. So please try to do your best to avoid hyperdeflection. 10 degrees, 20 degrees are enough for paraclinoid aneurysm. Don't do much more than this, okay? And this is an overview about the techniques that we can use for proximal control for intracranial aneurysm. And for sure, anterior clinoidectomy is a workhorse for this technique. Why? Because we have to get our proximal control just proximal to the takeoff and to the origin point of the ophthalmic artery here. And I want to lose too much time to review this kind of anatomy here about the clinoid region. But I want to show you what we need here. When we drill the clinoid, we have the opportunity here first to visualize the takeoff just below the optic nerve of the ophthalmic artery. The second one is to get our proximal control at the level of the clinoid segment of the internal carotid artery, to put the clip there and to reconstruct the aneurysm. So that's the reason why we need to do our anterior clinoidectomy. And our anterior clinoidectomy should be carried out until the so-called carotid cave, to fully expose this C5 segment of the internal carotid artery and to get my proximal control to this kind of aneurysm. This is a number case of mine. This is 45 years old, ruptured aneurysm, small aneurysm, but ophthalmic superior projecting. And I want just show you the main steps of the anterior clinoidectomy. These are the main steps of the peeling of the lateral wall of the cavernous sinus. I always love to perform extradural, anterior clinoidectomy. I will take the space extradurally to get my proximal control to C5. I fully expose here the aneurysm just below the optic nerve. And now, before to do this, I have already took the look and I already defined the ophthalmic artery just to avoid my complication. And here now, the last step of surgery after clipping, this is the ophthalmic artery in ICG that I have exposed here, that is totally outside the clip. And the last step of surgery is decompression of the optic nerve, what usually we cannot do with endovascular therapy. We have to do some with endovascular therapy, flow diversion. We have decompression of the optic nerve very late in 6 months of when the aneurysm obliterate. And this is the postoperative digital subtraction angiography. And because of the decompression of the optic nerve, you see now here this beautiful, visual field test. These are the main steps of the anterior clinoidectomy. We have the unroofing of the optic canal, drilling of the lateral drilling of the medial aspect of the sphenoid ridge, and don't be shy to deal the optic tract also, because the optic tract is the key for anterior clinoidectomy. When you perform anterior clinoidectomy, we already performed the transcavernous approach. Why? Because the anterior clinoidectomy is the anterior part of the roof of the cavernous sinus. Okay? So that's what we see here in the red triangle. Okay? So we are practically speaking already from a transcavernous approach. It's a tailored, staged transcavernous approach to get the space to the clinoid segment of the internal carotid artery. But we can move forward to other steps and to other modular selection and exposure of the cavernous sinus, doing our peeling of the lateral wall of the cavernous sinus, reaching here one of the most beautiful triangles that we can have here. That is the infratrochlear triangles, the so-called Parkinson triangle, where we can put the clip. And this is the beautiful and elegant technique that Professor Krish used to get the proximal control to lots of this aneurysm in this area, in the anterior clinoid segment and even the cavernous sinus. This is a beautiful way. Some people believe that cavernous sinus is a so-called no man's land. But if you see as Professor Krish performing this, it's more simple than perform a simple clip or anything, because we have to know the anatomy and you have to be able to fully expose here this triangle. This is the most elegant way to get your proximal control and even to avoid the exposure, the unnecessary exposure of the cervical ICA in the neck for this very low paraclinoid aneurysm and sometimes also here cavernous aneurysm. But coming back to superior projecting aneurysm, I already told you that we can have dorsal ICA aneurysm. What are the difference? The difference is the fact that in the true aneurysm, we need to get a proximal control more proximal here. So we have to go more lower. For dorsal ICA aneurysm, this is side branch aneurysm. We have 3 millimeters, 4 millimeters, where we can put the clip just after the takeoff of the ophthalmic artery. And we don't need sometimes to expose the clinoid. Why? Because the anterior clinoidectomy has some risk, especially about the thermal drainage. So in this case, we have proposed a technical note for the paraclinoid aneurysm that I want to share with you. That is the optic foraminotomy. Optic foraminotomy is a concept just slightly different about the simple unroofing of the anterior clinoid of the optic canal. Sorry. Why? Because I made the 260-degree exposure of the optic canal, drilling the lateral part of the jugum sphenoidale and the optic tract especially. And I want to show you a case. This is a dorsal ACA aneurysm. This is not true ophthalmic. Why? Because the takeoff is 3 millimeter further, 3 millimeter distal to the takeoff of the ophthalmic artery. And in this case, this is a beautiful video of one of my best friend, Professor Campero, because we published an article together that now I show you. And I want to show you all the advantages in this kind of aneurysm to perform the unroofing and the optic foraminotomy. Here, the anterior clinoid has not been touched. Okay, and we can avoid the risk of thermal damage to the optic nerve, but we have to open the optic sheet to just lightly mobilize the nerve. But I have the space here to put the clip, and I have the space here to beautiful clip this aneurysm. And this is the post-op CT angel. It's just a technical note. So we have proposed this variation to the anterior clinoidectomy, and this is the postoperative visual field. And we have proposed some variation. We have put together our data with the Barrow group, and we have to publish this article where we compared 18 patients where we perform optic foraminotomy versus 25 patients in which we have performed anterior clinoidectomy. And here we propose this technical note for some small, very small, selected superior projecting DOSA ICA wall aneurysm. And we find the same rate of the aneurysm complete occlusion rate, and we have not worse approach relating visual outcome in this patient. So this is a nice technical note to use in some very selected cases. What about basilar tip aneurysm? About basilar tip aneurysm is the second most common type of aneurysm where we need to use the skull-based approach. We can have normal riding, high riding, or low riding, according about the fact that the bifurcation of the basilar artery can be above or below the bisclinoid line here. And we have lots of approaches that they have proposed to treat the normal riding as a basilar tip aneurysm. But the COZ approach takes some more advantages. It's very, very advantageous for this type of aneurysm. COZ approach has a beautiful spherical increase of my surgical freedom around the target, around the aneurysm. So COZ approach is beautiful also for high riding aneurysm. It's because COZ approach has a spherical shape in terms of the increase of the exposure. We can use COZ approach also in low riding aneurysm, okay? And even in COZ approach, we have to take advantage to use the pretemporal corridor performing the peeling of the lateral wall of the cavernous sinus, and we can reach the proximal SCA aneurysm lower than, okay? And here we can have lots of variation about the cranio-orbitozygomatic approach to COZ. We have one piece, two piece. The best for me is the very elegant variation of Professor Almefti about the orbitopterional flap and the mobilization of the zygomatic arch that for cosmetical and functional reason leave attached the masseteric muscle to the zygomatic arch. And here we can have an exposure. This is an article that we published a few years ago. Now, this is a beautiful exposure of the pterional versus orbitopterional COZ for some anterior communicating aneurysm first and basilar tip aneurysm also. Why? Because the removal of the orbital band take advantage to the anterior fossa, and the removal of the zygomatic branch take advantage to the interpeduncular system and the posterior fossa. These are the main steps, but I don't want to lose too much time. Dear, don't forget to leave the muscle cap for reconstruction. And here we have to do very compulsive. From the technical point of view, the COZ approach needs the true McCarthy keyhole. That is not the keyhole that we perform every day in, in pterional approach. This is a true McCarthy keyhole. Arthur McCarthy described this keyhole because this keyhole must expose orbit and anterior cranial fossa, and this keyhole must expose the roof of the orbit. And now here, why? Because in this variation, we have to do our extracranial cut, and we can take advantage from the COZ approach when we compare it. We have at least 46% of gain in terms of percentage of target exposure. And this is what we can do with this approach about the complete trapping of anterior communicating artery complex aneurysm. But I want to move forward here. And this is a case of complex aneurysm that we want to use the COZ approach. Why COZ approach? COZ approach is beautiful because it allows us a sort of deep windows. Some of these windows are related to the transsylvian exposure, and other deep windows are related to pretemporal, subtemporal exposure. That is another corridor related to the COZ approach. And we can also perform our pretemporal transcavernous approach through the drilling of the posterior clinoid to reach the interpeduncular system area here, and to reach our, as I showed you before, our proximal control to the infratrochlear triangle at the level of the cavernous sinus. And this is another case of basilar tip aneurysm when we use 3 different corridors, as we see here, 3 different working corridors and deep windows. The first one is the opticocarotid. The second one was the carotid oculomotor window. And the third one is the supraclinoid, when you have a working space just above the bifurcation of the ICA, below the level of the anterior perforated substance. This is an overview, and we see beautifully as the COC approach allows us in the posterior fossa to show and to expose the upper quarter of the clivus. And we have also taken advantage of from subtemporal, pretemporal exposure to even reach the second quarter of the clivus here. What about the mid-basilar trunk and other aneurysms? The mid-basilar trunk and vertebro-basilar junction today are at some historical why, because most of them are treated by endovascular therapy. But just to show the fact that we can use the Almefti combined petrosal approach here to expose this, we have to expose these aneurysms. When we want to expose these aneurysms, we practically perform a pre-sigmoid approach. And the pre-sigmoid approach, when we want to expose the sigmoid sinus, we have to put our burroll. And don't forget never that asteroid, it's not always a good landmark, and navigation can be useful because of the reason that I am showing you. And this is another beautiful paper of Professor Guzmão from Brazil that showed that the projection of sigmoid sinus is in between the asterion and superior digastric point. But sometimes when we deal these aneurysms and the pre-sigmoid exposure, we have to, consider the fact that the right sinus, the right sigmoid sinus, is usually the dominant one, is the larger one, and it can be very easy to expose the Trautmann triangle area here and to reach the exposure. And in 20% of the cases, we can have this type of anatomy, and this can be a relative contraindication. Another important aspect is when we perform these pre-sigmoid family approaches, we always have to take a look to the venogram, because we have to avoid to cut the labbe in those cases where the labbe on the venogram is empty directly at the level of the superior petrosal sinus. And it happens sometimes when the sigmoid sinus and inferior petrosal sinus are atretic or agenetic. So never forget to take a look to labbe and to venous drainage pattern. In these cases, Professor Almefti has proposed a so-called graceful petrosa where you can spare the vein of labbe. Just a few words about the posterior circulation aneurysm, especially vertebro-basilar junction pica aneurysm. For sure, we can use a far lateral approach and all these variants. Why? Because we want to take our exposure just in front of the dentate ligament, and we need to drill the condyle sometimes to take advantage to gain more space just in front of the dentate ligament. And here we can expose the lower fourth of the clivus. It is a totally different story. I want to go very fast here. I don't want to lose too much time to talk about the history of the far lateral approach, but far lateral approach has been burned, and unfortunately by a number of misleading nomenclature. But it's a beautiful approach for proximal pica aneurysm and vertebro-basilar junction aneurysm. Far lateral approach is a basic extension of the lateral suboccipital approach, where we can have the C1 hemilaminectomy and the drilling of the condyle that is various in terms of size. And here the positioning is very, very important. Why? Because the lateral bending is very important, is critical in this kind of approach, because we want to superficialize this part of the suboccipital region to expose the vertebral artery, venous plexus, and the vertebral artery. And we should be compulsive in the skeletonization of the vertebral artery here to avoid troublesome bleedings from what Professor Almefti called the suboccipital cavernous sinus here, and also to expose the V3 segment of the vertebral artery. Why? Because we need here to take our proximal control. Also here, you have to take a look to the angiogram or CT angio. Why? Because you can have some variation of the vertebral artery. Vertebral artery can finish in pica, and you have to know this before surgery and before to clip aneurysm. And in up to 20% of cases, you can have an extradural, extracranial origin of the pica that could be misunderstood as a muscle branch from the vertebral artery here. And we basically have two structures that hinder our view to proximal pica aneurysm. And the first one is the jugular tubercle here, that is the expression of the ontogenetic fusion between the lateral and the condylar part of the occipital bone. And the other one is the condyle. So we need to drill the condyle. Sorry about my presentation now. Okay. So we need to drill the condyle sometimes, and don't forget here the orientation of the hypoglossal canal at this level. Why? Because at the level of the hypoglossal canal, we want to, in the so-called transcondylar exposure, we need to drill subtotally the condyle, all the posterior part, and to skeletonize the hypoglossal nerve at the level of the hypoglossal canal, to take the space just in front of the dentate ligament at the level of the basium. And we have some variation of the far lateral approach. The first of these are directed through the occipital condyle. And in this case, we talk about the transcondylar approach. And some of them are basically carried out through the jugular tubercle. So these are the transjugular or supracondylar fossa approaches, because the jugular tubercle corresponds to the outside of the cranium to the retrocondylar or supracondylar fossa. And this is the exposure that we can have. Consider that in the transcondylar that they already called, that they called also extreme lateral approach, we can take advantage to reach the contralateral side at the contralateral anterior tip of the condyle. So we can work through the midline and you have the most tangential exposure as possible in front of the condyle, in front of the brainstem here. And these are the main vascular targets that we want to expose. When we talk about the cavernoma here, far lateral transcondylar approach expose this part of the brainstem. And this is a comparison between the minimal drilling of the condyle and the conventional far lateral approach and the transcondylar approach, where we can see not only a tangential that is as close as possible to the target and a surgical corridor view that is as tangential as possible to the target, but we can also have the shallowing, so the superficialization of the target here, where we can manage our lesion. And here we have the two different conventional corridors that are suprahypoglossal and infrahypoglossal corridor, and we can expose everything here. And when we expose here in the transcondylar far lateral approach, don't forget to expose the V3 segment, because here I can have the proximal control at the level of the extradural part of the vertebral artery before to expose this aneurysm. Don't forget to open the dura here, just medial to the vertebral artery. And here we can take advantage to expose also V4 segment and the takeoff of the pica and to elegantly treat this kind of aneurysm. I think that it's enough for me, and I don't want to stall too much time to my colleague here. And I want to thank you once again for this beautiful and kind invitation, and for all of you that want to deepen this aspect, we can they can take a look to bibliography that I put on the presentation. Thank you very much, and sorry about because probably I talk too much.
Dr. Sabina, no, it was wonderful presentation. Thank you so much for the sparing your time. And I just want to give comments to convey this comment to young neurosurgeons and tell that don't underestimate basic approaches. Basic is just the word. They are not as basic as we think. And it's all about details. So the devil is in the details. If you want to approach even craniotomy, pterygonal craniotomy in the proper way, you better go to details, you better read a lot and know all corridors, so that you will succeed in that case. So thank you so much. You know, this presentation will make me go again and read about especially posterior fossa approaches as well. So Dr. Ilya, you want to tell something, to give comments?
Yeah, do you hear me? Yeah.
Yes, we can. Mm-hmm.
Sabina, thank you for a brilliant lecture, and we see that you're a brave and excellent skull-based surgeon. But I have for question, one comic question. In your hospital, do you have an endovascular team?
Yeah.
In your hospital?
Yeah, sure. We have a beautiful endovascular team.
Yeah. That's good. And three questions about surgical strategy. How often do you use neck artery control before skull-base surgery?
Especially for paraclinoid aneurysm, more when they are very, very low. But I usually tend to use the, cervical ICA control for true ophthalmic aneurysm. So that very, very low aneurysm and very complex, huge, when the origin of ophthalmic artery is involved, into the aneurysm, especially when we are giant thrombosed calcified. But in the recent year, after I saw the Professor Chris technique, I want to change my mind. I'm just a little bit scared because, you have to know very well that kind of anatomy. But in my near future, I want to be able and I want to study and I want to come back to the lab to study the possibility to expose the infratrochlear triangle and to get your proximal control, because it is not so difficult if you know anatomy of the cavernous sinus. And he showed it to all of us in the world that is the most elegant way to take the proximal control. So I do believe that in the near future, if you learn very well the anatomy of the cavernous sinus, we'll need no more to expose any cervical ICA, even for complex ophthalmic aneurysm. But this is my point of view, and I have my school, and my school is the same of, Professor Christian, Professor Almefti. This is my idea. Okay. But you can expose that kind of the carotid. Then I show you on the cadaver that you can put just a clip there and try to clip, and the bleeding from the cavernous sinus is no more a problem, because all of us can elegantly control with GELF1, with T-seal, any kind of bleeding from the cavernous sinus. So this is very, very elegant way to take your proximal control in this kind of aneurysm.
For young
Thank you for.
Okay. Do you use only extradural or combined method in anterior clinoid resection?
In most of the cases, I love extradural anterior clinoidectomy, even in ruptured aneurysm, because my chief in the past used it so much intradural clinoidectomy in all cases of ruptured aneurysm. But sometimes, you have angry brain, especially in high grade antes aneurysm, and this swelling brain can encroach and limit your working corridor. So today I perform in 99% of cases anterior clinoidectomy by extradural route and in extradural way.
Okay, thank you. Last question about medial cave ICA aneurysm. What's your opinion about contralateral surgery for?
Sorry. Which kind of aneurysm? I didn't hear you.
Medial cave ICA aneurysm.
Okay.
What's your opinion about contralateral surgery, or maybe what's your approach you use for medial cave aneurysm?
Let me tell you, I can agree with you about the fact that the angle of exposure, it's for sure better from the contralateral side. I totally agree with you. But you have to deal with the fact that you have zero proximal control.
Yeah.
And it can be very dangerous, especially for young guys. So despite the very, very good visualization of this kind of aneurysm, but let me tell you that also it is good for small aneurysm, for huge aneurysm, for huge and calcified aneurysm, when the optic nerve is upward displaced, your angle of attack of aneurysm is limited even from the contralateral side. But I have to choose to have the best exposure in terms of angular exposure of the neck of the aneurysm. And the proximal control, for sure, I will prefer to have the proximal control.
I agree with you. Okay. Thank you for answering my question. Thank you.
It's dangerous. You can do it in some very small, limited cases, but probably it can be a wrong message for young surgeons. Okay. So it's better to take proximal control.
Thank you.
Thank you so much for the nice discussion. I hope young neurosurgeons will take a lot of notes. Let me introduce our third speaker, Dr. Ilya Grigoriev, medical doctor, neurosurgeon, also from Federal Center of Brain Research, Moscow. Dr. Ilya graduated from Kazan Medical University. The residency was graduated from Polenov Medical University, which is in St. Petersburg, and the pre-PhD work was done in emergency hospital named after Dr. Sklifosovsky. So today, Dr. Ilya Grigoriev will be talking about gliomas. What do we know about that? It's more philosophical topic, and we are looking forward to listening to you. Thank you.
Thank you very much. Do you see my screen? Could you hear me?
Yes, we can see your screen.
It's okay, yeah?
Yeah, perfect,
Yes.
perfect.
Thank you very much for introduction. Me on your conference. It's very important for us to discuss and share our thoughts about different problems in our field. And today I want to discuss with you the problem of gliomas. First, a small talk about our clinic. It is rather young. We are opened only in 2019. We are located in Moscow. We have two operating rooms, one with intraoperative MRI suite, one with angio suite for endovascular surgery. And the main topic of our work is neurosurgery, neurology, rehabilitation, and cardiology. So we knew that gliomas are most aggressive and most common primary brain tumors in our practice because of rather malignant biological behavior. How much people do we have in Russia a year? It's approximately 7,000 people a year. It's a huge amount of people. For example, in this rather big hockey stadium is about its capacity is about 8,000 people. Now we have a new classification of tumors of the CNS, and the main criteria for them are molecular diagnostic, not only the microscopic appearance. Today we're going to talk about the astrocytoma, oligodendrogliomas, and glioblastomas. We could differ all gliomas in biological behavior and divide them into two groups, low-grade and high-grade groups. But now we know that different grades are steps of one process, and I think every one of you saw the patient with the previously diagnosed low-grade glioma that begin to accumulate the contrast and become more malignant. Unfortunately, gliomas tend to become malignant, and when we saw the untreated patient with grade 2 gliomas, it takes approximately 5 to 7 years to become the glioma more aggressive. Here on the graph, we saw the rising price of the Apple stock change, and so did our tumors. They are always grow, unfortunately, and the average rate of growth is approximately 3 to 5 millimeters a year. So we knew now we knew that wait and watch strategy is no longer viable because they tend to grow and gliomas tend to be malignant. Statistics, unfortunately, is not on our side because we knew that the patient with the high-grade gliomas usually couldn't live longer than several years, and only 5 to 10 patients of the people could live longer than 5 years. But there are three kinds of life, timeline, and statistics, and we found this interesting correlation between the divorce rate in Maine correlates well with per capita consumption of margarine in US, but this is not logic, of course, but the coefficient of correlation is really high. we must be honest with the patient and caregivers and our colleagues. We couldn't cure gliomas, but we could alleviate some symptoms to improve the quality of life and extend their life. What we could alleviate? We could lower the deficit, lower the pain, and make the patient free of seizures. But now our philosophy of brain organization are outdated. When my colleagues talk about the functional zones, they said that this glioma is in the functional zone. I pretend this picture where some functional areas are showed in different colors, and we think that when we have surgery in different color zones, we usually have a neurological deficit, but the other brain is functional too. So the brain is a non-linear system, and if we destroyed only one small interconnections, the other could take it function, and we saw it because some patients have restore of initial functional deficit after surgery, because brain could reorganize itself, and we saw that verbal tasks activate two hemispheres, and for example, as the tumor grow, we see the migration of the some for example centers of speech. Connectomics is a new brain paradigm that said that whole brain has its own function. There is no non-functional areas, and the brain consists of small hubs that have primary, secondary, and small and little interconnections. And the surgery, good surgery without causing a new deficit, might be contrast on these small interconnections. So now we have three options: the biopsy, the resection, or laser interstitial therapy. It has own pros and cons. But when we talk about the biopsy, firstly, I thought when I only come to neurosurgery that biopsy is good viable options without complications. But biopsy does have complications. Mortality could be up to 4%, and clinically significant hemorrhage could be in rather 10% of people. This is our clinical case for putaminal hemorrhage after the needle biopsy. We saw after 1 hour clinical deterioration of patient with a depressed level of consciousness. We performed several CT and saw that initial intracerebral hemorrhage have expanded, and we need to perform the evacuation of the hematoma. So maybe there is a place for so-called open biopsy, where we could take the biopsy, control the biopsy, and any bleeding by our microsurgical skills, microsurgical instruments, use the bipolar and use the microscope. Radicality is our main factor because extent of resection influences the overall survival, quality of life, temps of malignization, and seizure control. Main dilemma of our work is maintaining a balance between the extent of resection and functional outcome, because we all have patients where we tend to further extend the radicality of resection, and the patient wake up after the surgery with a new deficit, and then we thought, oh, I don't need to remove that small amount of tumor. But how radical we should be? If we talk about the contrast positive tumors, we talk about the resection of the contrast enhanced zone. If we talk about the contrast negative tumors, we talk about the resection of the zones of hyperintensity of the T2 or flare. Apparently, to influence the overall survival, we need to resect as many as 70% of initial tumors. But is 100% of resection of zone of enhanced contrast is a limit? No, now we know that lobectomy, or so-called supramarginal resection, in contrast with the well-known gross total resection, could provide the patient with the better overall survival, better progressive-free survival, and these methods could be equal in complications. And is it always necessary to sacrifice extent of resection for the sake of neurological deficit? It's a matter of debate, because now we knew that when we have a tumor in the supplementary motor area and damage the frontal acetylene tract, we saw the hemiparesis and aphasia in patient, but they regress in 95% of patients in 2 or 4 weeks. Could it be a signal to stop the resection? It's the matter of debate too. What about resection methods? Now we could divide all of resection methods into the 2 principal stages. It's an inside-outside technique or outside-outside technique. When we talk about the glioma that project on the cortical surface, we found very useful to use the sub-PL sulcus-guided resection techniques. Firstly, we perform a 3D reconstruction of flare and see the tumor, could border it on the borders. Then on the microsurgical stage, we could border the tumor by the sulcus guidance, and we find that using these techniques have a higher extent of resection and less complications, because you don't damage the arteries that located not only on the surface but on the sulcus. This patient with the astrocytoma grade 3 that were located in the post-mortem area, we use this technique to achieve gross total resection of tumor with no additional deficit. The other case is the glioma in the right premotor zone. We use this technique too and achieve a gross total resection without a new neurological deficit. But how could we control extent of resection? Now we have different methods. It's the fluorescent guided resection, neuronavigation, ultrasounds. The main idea for using all these methods is reveal residual tumor volume and extent of resection. But all of these methods have their own pros and cons. But it's not enough. Apparently, everybody, unfortunately, have patients with non-radically removed gliomas. And we make these Stanley Cup playoffs and to compare different methods of intraoperative control of resection to know what is maybe best. First, 5-ALA, all well-known method. It's simple, real-time navigation, but only 20% of grade 1-2 gliomas accumulate 5 ALAs, so we couldn't use this method for all gliomas. When we compare the volume of resection that was leading by the neuronavigation and the volume of resection that was fluorescent guided, the second one is more by the volume. So the neuronavigation based resection could be not radical. And as the Marcus Aurelius used to say, fluorescence is tumor always. Then when we compare ALAsense and 5-ALA versus the navigation, the 5-ALA have better in overall survival, progression-free survival, and extent of resection. Now in the Stanley Cup final, we have a fluorescent guided resection and intraoperative MRI. But what we get with the intraoperative MRI technique? Apparently, it's the high-quality real-time images that could be multimodal, its safety and low number of false results. But apparently, this technique has a huge minus. It's the high price and prolongation of operative time and need for surgery stop. This technique has a bright evidence-based, reliably improve extent of resection, and IMRI reveal residual tumor in roughly 70% of performed cases. This is our case. We perform an intraoperative MRI when the surgeon thinks that he conduct a gross total resection and reveal small amount of tumor on the medial side of the resection cavity. Then when we go back to operation room, we resect this small amount of tumor and could collect a gross total resection. The other case is a 33-year male with a grade 2 astrocytoma. We perform a intraoperative scan and reveal a small residual tumor on the posterior resection side, so we could complete this tumor resection without the new neurological deficit. Now we knew that 5LA is better delineate the infiltration zone, but in contrast, positive tumors, maybe 5LA and IMRI equals in positive on effect on extent of resection. And if you combine both methods, you could provide maximal extent of resection. It's in high-grade gliomas, but in low-grade gliomas, we don't know because only roughly 20% of them accumulate 5LA. Now we know that there is no golden bullet, the best method for the control of extent of resection, and it's mandatory to always use any control method, and of course better combine different methods in real-time patient depending on your clinic capabilities. Like the seller said, Veni Vidi Vici, and in our case it's Veni Vidi Vici and Vidi Vici, again with LA or intraoperative MRI. Thank you very much for your attention and the opportunity to share our experience.
Thank you very much, Dr. Yeah, wonderful. Literally wonderful presentation. And yes, I'm sure after that we will change our mindset regarding the glioma management, and we'll try to be better. Anybody has comments or questions?
I have a comment.
Yes.
Can I?
Of course, Dr.
Of course.
Congratulations for your beautiful presentation. It was very exhaustive about the general management, and I appreciate it so much, especially some technical details about superior resection and sulca by sulca resection that are very, very important concept to increase and to maximize the extent of resection. First comment, what do you think about, because I use it in the past so much, because I was very curious at the beginning of the history. The fluorescent tracer, fluorescein, 5LA, and what do you think about the real advantage, of improving, of implementing this kind of technique in your surgical workflow? Because I tried to play with these toys, so much in the past, but I realized that not the sensitivity, but I no more trust to that kind of tracer. Why? Because we have some of drawbacks in using especially fluorescein because of an extravasation, okay? And because of sometimes even different metabolic pattern and visualization pattern of 5LA also, okay? So for me, it's not the key to find the border of the glioma. And the personal, and after my fellowship in Istanbul that totally changed my life, I realized that probably the experience of the surgeon is still superior to this kind of tracer. Now, I see here one of my best friends, a brother online, and I'm more than happy about him, about Professor Ramanov, okay? And said there is a fellow, Professor Ture, still there in Yeditepe University. I want to say hello to him. I'm very honored that he is here. And I want to involve him in this discussion, because I know that you share my same philosophy, and Professor Juliet doesn't know tracer, because, you know, experience is everything. But what do you think about?
Hello, everyone. I can say just Professor Ture's option. He always checks the ultrasound ultrasound techniques, and also he also uses near navigation. But near navigation, he's sometimes it's correct, sometimes not. But he always using ultrasound.
But he doesn't use tracers, flourish and tracers, because he doesn't trust in that kind of. But
Yeah,
because of the that we were talking about. But yeah, but I want to. But what about Professor Grigoriev? What do you think about this kind of? Because the question was for the speaker. Do you trust in this technique?
Sabino, thank you for your question. It's really interesting. Unfortunately, we don't have any experience in the use of fluorescein, but we have, I think, a good experience in using 5-ALA. Firstly, when I conduct a surgery on gliomas, when I only perform my first surgeries, I have difficulties in the border zone of the gliomas. I really don't know where to stop the resection, because this border zone is not good with seen, not good seen only in the light of the microscope. Then we use the 5-ALA, and we saw that the extent of resection is better. Then when I become more skilled in this surgery, I started to better delineate this border zone of the gliomas, and use 5-ALA only like a final control. But when I only talk about my surgery, I think that adding a 5-ALA is good method, because yes, it has its own minuses, like the price, for example. But you could have 10 surgeries without 5-ALA and have one residual patient with residual tumors. But you could use 10 patients, you could operate 10 patients with 5-ALA, and imagine if in one patient 5-ALA could positively react on the extent of resection. 1 out of 10, it's more than we need, because the extent of resection is our main goal. It's the only modified goal that we could control. It only depends on the surgeon. We could not cure the patients. We couldn't change the molecular biological behavior of these tumors, but we must perform the radical surgery. No matter how you do this with 5-ALA, intraoperative MRI, ultrasound, or something. You just need an additional techniques to be honest with you, with the patient, and to be 100% to 100% new that there is no any additional tumor in the cavity. How you achieve this goal is only on your decide.
Okay. My last comment is about intraoperative MRI. I saw on your picture that some group report a rate of tumor remnants that was found with intraoperative MRI that is up to 70%. It means that in 70% of cases we found a remnant with the intraoperative MRI. I do believe that these data are also coming coming only from some very, very small group, and we have to take with caution, okay, this data. Because if it is totally true, we should stop to operate glioma if we don't have MRI in our clinic, you know, and intraoperative MRI, I mean. Because it means that we have the chance to leave tumor there in 70% of cases. I do believe that probably this data is very, very exaggerated, because coming not from you for sure, you reported the data of the literature, but coming from some small group, and we have to take with caution this data, because, you know, if they are not data coming from trial, okay, or multi-center experience. They are data coming from some small groups where the skillfulness and the global and the overall experience of the surgeon play a pivotal role in doing this, okay? So it can be a wrong message, because it means that if we don't have intraoperative MRI, we should stop to operate glioma every day. And this is too much, probably. MRI, for sure, is a very, very useful tool, helpful tool. I saw very rarely to find in the hand of Professor Zuri that is the god of glioma surgery, for sure. I very, 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 very rarely to find some tumors. Or okay, in my hand, for sure, it will help me. It could be help me much more than him, because I'm not so good like him. But anyway, 70% probably is exaggerated, because coming just for a group. And this is just a comment. It's not a question, but it's just a comment. We have to be very careful in the interpretation of the data coming from the literature also. That's it.
Thank you. Let me please comment this. I agree with you that 70% is a huge amount of tumor that was diagnosed, residual tumor that was diagnosed. I think this huge number is because of, firstly, when surgeon know that he could perform an intraoperative MRI, he could perform, he could stop and check his work before he stopped the surgery. Maybe it's because of surgeon think that, okay, I maybe resected on more than 90%. Now I will check and then re-resect it if I need.
Also,
the second one.
Sorry. Go ahead. Go ahead.
Second, thank you very much. The second one is maybe because in that cases they always use quantitative percent of tumors. They calculate the volume of tumor pre-op and post-op, and they have a volume analysis. Now in Russia, not in all clinic, we use volume analysis, and the final extent of resection is only by the surgeon eye. You saw your post-operative MRI, and you think, okay, it looks like gross total resection, or it's near total resection, but it's only on your eye. When you use the computational method of volumetric analysis, you could reveal a small amount of tumor, 1% or something like this. And that's why intraoperative MRI with volume analysis, pre-resection and post-resection, could have this huge amount of non-radically resected tumor initially, because of the volumetric analysis, not only by the judgment of the surgeon eye.
We'll see in the future. It's a helpful tool, but we'll see. We have to focus much more on the real advantages coming from the routine implementation of intraoperative MRI. Thank you so much.
Thank you.
Thank you so much for nice discussion. Yes, I can see that we almost don't have any questions, maybe because today's topics were full of, information where you cannot just randomly go and ask some questions. So we have to think and it's according to the big experience of surgeons who were talking today. If anybody wants to give any other questions or comments.
Yeah, one comment. I think there is no question today because we all are microsurgical enthusiasts, and we don't question that the microsurgery is best surgery that could be.
Yes, yes.
Totally agree with you.
Deeply
Long
agree.
life to microneurosurgery.
And regarding the skull-based approaches of the topic of Dr. Sabine Luzi, I want to tell that yes, one day James Liu, the neurosurgeon from USA, told that nobody ever died from big approaches. And if we talk about minimally invasive approaches, it's a really big question. When it comes to big tumors, you have to think twice or thrice before you go for minimal invasive approaches. And this is also a very important message for us, for young neurosurgeons as well.
Minimal invasiveness is not in the size of the craniotomy of the skin incision. Minimal invasiveness is in the knowledge of anatomy and respect of anatomy. That's the key concept, okay?
Yes.
It's really interesting that nobody died from the big approach, but I saw some people that died from the small approach.
Mm-hmm.
Sure. I saw people die because of a supraorbital keyhole approach that aneurysm intraoperative rupture, and they don't have proximal control. So that are not the typical kind of lesion where to start minimal invasive keyhole approaches, because as Professor Almefti say, less is less, you know? So, okay.
Okay, let me announce our next webinar, which is going to be 12th of November. We're going to have around 4 speakers and 2 young neurosurgical residents. So I will send the banner to everyone. And also we have from our panelists today good people. One of them is Dr. Francisco. He's from Italy. If you want, you can unmute yourself and introduce yourself. Dr. Serdar Rahmanov, let me one more time mention. He's a neurosurgeon from Turkmenistan who studied in Russia, and right now he's doing his fellowship in Istanbul. Dr. Shahid Hassan is the neurosurgical resident from Bangladesh, from Dhaka Medical College. They also have very big amount of endovascular as well as microsurgical cases. And Olga Kardonskaya, I think a neurosurgeon from your center, am I right?
Yes.
Yes. If you can introduce yourself, we will be very glad. Thank you.
Thank you a lot for everyone. It was very interesting discussion. Thank you.
Yeah, I'd like to thank all you guys. A very interactive discussion. And I didn't introduce Nargiza properly. I should know how to do this. Nargiza is a neurosurgeon from Uzbekistan, and she put this together. And she's currently in Turkey now, doing part of her pediatric neurosurgery. Sorry about that, Nargiza. I didn't introduce you properly. Anyways, we'll see you we'll see everyone in 2 weeks. Great session. Thank you very much.
Thank you.
Congratulations once again to this beautiful lecture, this beautiful webinar, and thank you very much to Professor Satova. Nargiza is my best friend, and congratulations. Thank you for the technical support and the beautiful introduction from John, that is our boss. Thank you.